Our next talk is by Dr. Robert Frankel, who's a dear friend of ours and a pioneer in many ways and also a trailblazer. Dr. Robert Frankel is the Director of Interventional Cardiology in the Cardiac Catheterization Laboratory at Maimonides Medical Center. He's a fellow of the American College of Cardiology and is triple boarded in internal medicine, cardiovascular disease, and interventional cardiology. He joined the Maimonides faculty in 1984 as a resident, well, actually, as resident first in internal medicine, and was subsequently a fellow in both cardiovascular disease and interventional cardiology. He's a former president of the Maimonides Medical Center House of Staff Association. He's a native of Brooklyn, actually, a graduate of Brooklyn College. Dr. Frankel earned his medical degree at the Universidad del Norte in Mexico. He completed the fifth pathway program at SUNY Downstate, again, locally homegrown, before beginning in residency in MIMO. Dr. Frankel is a leader in the use of new technologies, including the road bleeder and the intracoronary laser. He also started a structural heart disease program in Maimonides. He has co-authored many publications and in journals and also book chapters. Dr. Frankel also has served on the New York State Cardiac Advisory Committee, is also a member of the Maimonides and Heart and Vascular Center team. He's a professor of clinical neurology, clinical medicine at SUNY Downstate. Is also affiliated with the American Medical Association Society of Cardiac Angiography and Intervention. Please join me to welcome Dr. Frankel to talk about the Brain and Heart Initiative at Two-Way Street.
Good afternoon, everybody. I'll try to make this brief. The hour's getting late and we're getting close to lunch, so we'll see if we can move this along. So my disclosures, I'm a proctor for a Medtronic core valve. That's a heart valve replacement, a TAVR procedure. So it has no bearing on, we're not going to be talking about that at this particular venue, so it should not affect anything in my talk. Go forward. So we have a patient, typical patient, 48-year-old woman. She's got some risk factors, SLE, rheumatoid arthritis, former smoker. She had a stroke back in her home country of Albania. She did an echo here at Maimonides, which showed positive for bubble study, and I'll show you what that looks like. Consistent with a PFO, possible ASD, atrial septal defect, good ejection fraction. She had a transesophageal echo, which is usually part of our workup, which revealed a mobile aneurysmal atrial septum, and I'll show you what that looks like with a large patent foramen ovale, also known as PFO, strongly positive bubble study, and a ROPE score of about 6. So we treat a lot of patients who have defects in their atrium. We started treating patients with atrial septal defects, such as the primum ASD. That was one. We don't really treat primums. It's too low. The primum occurs down here, too close to the atrioventricular valves, also known as the mitral valve and tricuspid valve. If you try to put a disc in that location, it'll interfere with the valve function, so we don't treat that. Primum ASDs go to surgery. Secundum ASDs are what we treat routinely, and that's up over here, and we have devices that we can put in there to close that up, and I'll show you some videos on that. Let's go forward. So pretty much this is what it looks like if you had an atrial septal defect. You can see here left atrium, right atrium, and there's a hole over here, a defect. What we do is we pass our catheter across that hole, and then using the Amplatzer device most of the time, but it's not the only device that is available, we start to push out this disc. And it's basically 2 discs. Looks like 2 umbrellas, double-sided umbrella. So we put out the left atrial disc first, and then we pull that disc back towards the septum, and once it's close to the septum, we get some resistance there, then we push out the right atrial disc, and once we're pretty sure that we have a good strong hold on that septum, then we will release the cable, leaving the disc in place. This is what it looks like on echo. You can see here, this is a patent foramen ovale, and you have the septum primum here, septum secundum here, and you can see that there's a defect in between. It's sort of like a flap. It's not really a hole per se, but there's sort of like a flap, like a trap door. So if one was to raise the right atrial pressure, you could sort of imagine that this floppy primum can pull back, opening up this door to anything that might come across that septum. So what comes across that septum that we don't like to come across there is clots. So if somebody had a clot in the femoral veins, deep venous thrombosis, any kind of pea-sized clot that was going to travel north, if you had an intact septum, what would normally happen is it would stay on the right side. A right-sided clot comes up the vena cava into the right atrium, and then it goes from there, it would go to the lungs. So you might feel a little pinch, something in your lung, in your chest. You go, what was that? And basically, you could have had a little tiny clot, pea-sized clot, that went to the lung, caused some discomfort, some pain, but then it just dissolved. And so on the right side, small-sized, pea-sized clots are usually benign, and they go away. However, if you have a defect, whether you have an atrial septal defect or more commonly a PFO, patent foramen ovale, when that clot comes up, if you happen to have coughed or had increased pressure on the right side, this trap door could open, allowing that clot to go from the right side over to the left side. And that's when things start to get ugly. Because when it goes on the left side, even a small size, pea-sized clot goes from the left atrium to the left ventricle, gets ejected out the aorta, and the next stop is the brain. The brain is a very good filter for these little clots, unfortunately. So if one of those little clots gets stuck up in the circulation of the brain, you wind up obviously with a stroke. There are other types of embolic phenomenon too, which occasionally we get called for, is if you had, somebody else mentioned retinal artery occlusion, right? So you could have a clot on the left side, it could go to the brain, causing a stroke, and that's the most common indication that we have. It could also go to other vessels. It can go to the eye. I've seen it go to the spleen, cause splenic infarcts. I've seen it go to the abdominal circulation and cause abdominal infarctions. So we do get called occasionally for that, but the most common reason that we get called is for stroke. So you can see here, we have this defect here. We take a catheter and we sort of push this primum open a little bit. We have to find the defect and push across it. When we do get across it, you can see here, we have sort of a wire or device delivery system that goes across it. Once we're deep in the left atrium, we open up that disc, we pull it back towards the interatrial septum, and once we think we have a pretty good hold on that septum, we'll release the cable. Here you can see the delivery cable here. Here the cable is already off and the device stays in place. So what are the indications? So obviously a patient who has a stroke, positive study to show that there is a pathway for emboli across that septum, and we have to make sure that there's no other cause for stroke, that stroke is in fact cardioembolic in nature or cryptogenic. And I'll just briefly go through a couple of these trials. Initially, goes back a while, but initially it was a very, very interesting time. So I've been doing this a long time, before it was really approved for first-time strokes. I'll never forget the first patient that I had. She was referred to me from neurology. This patient had a severe stroke. She was hemiplegic on one side. She came to Maimonides, and the Maimonides neurology interventional team took her upstairs to the interventional suite, did some sort of a clot extraction on her, and followed it up with some TPA or TNK at the time. I'm not sure which one. And this woman who was hemiplegic had like a 99.9% recovery. Phenomenal. Great, great success story. She comes to see me in the office, and back in the good old days when we first started doing this, believe it or not, the government wouldn't allow us to put in a device after the first stroke. We could only put a device in if the patient had recurrent stroke. So here I had this woman in my office, 50-some-odd-year-old woman who's hemiplegic. And I had to tell her, look at her straight in the face and say, I can't close your defect, not until you have another stroke. And she looked at me like I was crazy, like, why would I risk becoming hemiplegic again for you to close this defect? I might not be that lucky next time around. Maybe they don't get all the clot out. Maybe I remain hemiplegic. So thank goodness, within the next week or two, they lifted that restriction, and she was my very first patient who got closed, and we still talk to this day. It's more than probably 10 years or something like that. I don't know, but she's doing great. And so some of the complications, when we think about closing up these defects, what can happen? So we see arrhythmias, and arrhythmias are probably the most common complication that we see from this. You're putting a device, a foreign object, into the heart on the septum, and it can get irritable. So most common things are APBs or atrial fibrillation. In all the years we're doing it, we had one patient who went into atrial fibrillation. He remained with us overnight, never needed any therapy. He converted back to sinus rhythm by the next morning. So that was the only complication that we've seen here. Device embolizations, when it happens, it can be a problem, 1 to 2%. So if that device, if the atrium is not strong, if it doesn't get a good grip on it, it could embolize, fall out of the atrium. So if you're lucky, it'll stay on the right side, but if you're not so lucky, it can fall into the left side. If that device goes into the left atrium, it's retrievable. We can go ahead and take a snare, go across that interatrial defect and try to grab it and pull it back. If you're really unlucky and that the device goes into the left atrium, if it should fall down and go through the mitral valve into the left ventricle, they say you're supposed to send that patient to the operating room to have it removed, in which case they would put a patch on the interatrial septum to close up any of the defects there. Vascular access complications can occur. Strokes from the procedure due to an air embolism can occur, also less than 1%, less than 1%. Pericardial effusion, if you're a little bit rough with the atrium is a relatively thin structured wall. You can get pericardial effusion, tamponade. Delayed reactions, very, very unusual, very unlikely. They talk about an allergic reaction to either nickel or the device itself. So this device that we use, the Amplatzer device, is made out of a special metal, and that metal has nickel inside of it. So if people have a nickel allergy or supposed nickel allergy, I'll usually send them to an allergist to confirm that or get desensitized to it. Thrombus formation on the device, also a complication, no complication, very, very rare. Patients post-procedure, once this device is in place, are treated with aspirin and Plavix. So it's a very rare occurrence. Device erosion, that was something that was seen years ago, and we still talk about it today. So if the devices are properly sized, there should be no erosion. But if the devices are large, the nitinol discs on this device can be irritating to the aorta. So if this device sits up against the aorta and there's a lot of movement with time, it could cause an erosion and a fatal event, very bad tamponade or a fatal event for a bleed. So we don't see too much of that. So the first clinical trials were pretty much negative with the first devices that were out there. So Closure 1 was not a good study. The next trial, which is really what got this device approved, was the RESPECT trial. And so what happened in the RESPECT trial, the reason that it was slow to get approved is because if you look at this first line here, intention to treat, they looked at patients who were getting the device plus medical therapy versus medical therapy alone. And if you look at that trial, it was a negative trial. It didn't reach statistical significance. 0.08 was the p-value. But that was on an intention to treat protocol. Just briefly, intention to treat means if you get assigned to the device arm, you're in the device arm. If you get assigned to the medication arm, you're in medication arm. But if you're assigned to the device arm and for whatever reason you get cold feet or you just get a cold and you can't come, you don't get that procedure, you don't get the implant, you are still assigned to the device arm, even though you didn't get the device. Now, that doesn't make a lot of sense to me, but yeah, you were in the device arm. So when they look at those patients that were in the device arm, even if they didn't get the device and they had a bad event, they had a stroke, it was a negative against the device arm, but the patient never got the device, so they couldn't be protected. So it didn't make a lot of sense. When they looked at it as treated, you see those patients who got the device versus those people who did not get the device, and in the medical arm, it was a statistically significant benefit to have the device in place. So there was a little bit of slow adaptation. The purists were kind of concerned about this intention to treat, and so it was a slow adaptation by some of our colleagues. But eventually, they did longer-term studies, and all the subsequent studies pretty much showed benefit, positive going forward. So you look at the Gore-reduced trials and you look at the extended follow-up from RESPECT trials, you can see that the p-values are statistically significant out to the third decimal place. So let's just keep going. So when we take a look at what patent foraminal valley looks like to a cardiologist, you guys send a lot of patients for bubble studies, right? We love bubble studies. So I'll see if I can show you what this looks like. But let me just orient you. The top chambers, there's two chambers up here. This is the left ventricle, this is the right ventricle. And the bottom chambers down here, that's the right atrium, that's the left atrium. So it's sort of like upside down. The ventricles, which you always think are on the bottom, when we get echo pictures, it's really on the top here for us. So what this bubble study is, it's nothing too fancy. We just take two syringes, two 10cc syringes connected by a stopcock, and we fill up one syringe up with 10 cc's of saline, normal saline, and we just inject it back and forth, back and forth, back and forth, and it creates these little micro bubbles. And then we take these micro bubbles and we just inject it through an IV, and what happens is the right-sided chambers you see fill first. They get full of these micro bubbles. They basically turn white. So you really shouldn't see any white on the left side. So initially everything's black. We fill up the right side. We give an injection into the veins. It goes from the venous circulation back to the right atrium, right ventricle. And you'll see over here, as I play this slowly, that the bubbles go from the right side, from the right atrium, across here into the left atrium. And see that momentarily. So now you can see that the right side here is full of bubbles, right? And if you look right at the left atrium, you'll see a puff. You're supposed to see a puff. There it is. So you can see here that these bubbles are going right into the right side, over to the left side, and then from the left atrium, right? The left atrium now has these bubbles in it here. It's going to go in and fill the left ventricle. So you shouldn't see any bubbles. You see all this puff of white? This cloud of white is highly abnormal. That's not supposed to be there. So they used to make us count bubbles to see if it was a significant shunt. So greater than 5 bubbles would be significant. This is a massive amount of bubbles that you couldn't even count. Probably, more than 100, 200 bubbles here going across. So this is a massive defect for this person, and it fills up the left atrium and left ventricle. There should not be a single bubble going across. You really should have no bubbles at all. One of the things we also do, sometimes we do it at rest first, and then we try to do provocative things. So to raise the pressures, we ask the patient to cough or do a Valsalva. And in this case, with the Valsalva maneuver, we had massive amount of bubbles coming across. So when you raise the pressures, you get this snow cloud effect. So what do? So we bring the patients to the cardiac cath lab, and now we do a different type of imaging. This was not available when I first started doing these procedures. We used to do it with transesophageal imaging. So initially we put the patient to sleep, intubate the patient to protect the airway, put a transesophageal probe into the esophagus so we can get good pictures of the heart and the atrium. Subsequently, though, we've developed the intracardiac echo. So there's actually a catheter that I put next to the delivery catheter. There's 2 catheters in the venous system. So in the femoral vein, I put 2 catheters, 2 large catheters, both 10 and 11 French or 10 and 12 French, one to pass the device and one to image. So we actually go up the femoral vein into the inferior vena cava, up into the right atrium with this ICE catheter, intracardiac echo. So we actually have an echo probe sitting inside the heart in the right atrium, looking directly at the septum. And with that, I can get exquisite images of the cardiac structures. So what you see here, you see this thing bouncing up and down? That's actually the interatrial septum. I call that a jump rope septum. It's just floppy as you can imagine. That's considered to be one of the high-risk features for recurrent stroke, and one of the indications really to move forward. So a large amount of bubbles, one indication it's a high-risk feature, and this floppy atrial septal aneurysm, and that's what you're looking at here. So that's a pretty bad septum that's flopping up and down. Now you can imagine when you go to put a device on that septum, like go to hang a picture on the wall, you want a nice piece of sheetrock or a piece of wood when you bang that in so that when you put that picture on, it's stable, it's not going to pull out. Same thing happens when we go to close up a hole in the heart, put a device in. I would like to have a really good stiff septum so that when I grab that septum with this device, it's not going to pull through. But you see how floppy that is, right? So it's conceivable that we can grab that septum and that device is just going to pull right through it because it's so soft and floppy. You'll see this other thing up here. That's a catheter going. It's going to be going through the PFO defect. And here you can see my catheter. It's actually going right across. This is the septum primum, this thin thing here, and this is the septum secundum right over here. And this is the delivery sheath that goes from the right atrium into the left atrium. And momentarily, you'll see us pulling back that disc. We pull that disc from the deep inside the left atrium. We pull it back across until we start to hit the septum over here and feel some resistance. Once we feel that resistance and we're pretty sure we're pretty much tight against the septum, we will release the other disc, right atrial disc. And now what we have, we have one disc. You can see that the left atrial disc is designed to be a little bit smaller than the right atrial disc. And that's good because we have less material on the left atrial side, hopefully less risk of clots forming on that disc. And what you see here is, we call it the Minnesota wiggle. Why the Minnesota wiggle? Because Amplatzer device was, Dr. Amplatzer is up in Minneapolis, Minnesota. That's where the factory is, where he makes all these things. And what I'm doing now, you can see a delivery cable attached to the device, and I'm pulling pretty hard. You see the device sort of being pulled up. I'm pulling pretty hard on that septum, trying to knock that device out. If I pull it out, it means that I probably need a larger device. If I can fit a larger device in there to get more purchase, or it's not going to sit and it's too much of a risk to leave it in there, and the patient may need a surgical operation to close this thing up. But you see us pulling pretty hard on that. We're trying to open that whole thing up, and it's not coming out. So I'm feeling pretty good about that. And then I want to make sure that I have septum. Here it's very obvious. We have the septum secundum, delivered into the disc, right? But it's not as easy to see on this side, the septum primum, because it's much thinner, whether or not I have it inside, whether it's inside that disc or not. So we take a few more images of that. We turn some color flow on to see if we have any flow around it. And at the end of the day, it looks like we do have purchase here, and we do have insertion of that primum into the discs. And so I feel pretty good about letting go of this device. And once we do that, the device will sit better. Let's see if we can get it to play again. Blue screen of death, that's never a good sign. Never a good sign. In any event, while Bill Gates is sipping a cocktail somewhere in the Caribbean, I will do this, anyhow. So Ankit's on it. Don't worry, he's on it. So anyway, so once that device is in place, then the procedure's finished. We basically send the patient back upstairs to the recovery. The patient recovers for a couple of hours, after which we get them up, walk them around, and then before we let them leave, it's a same day admission, in and out, same day. We get another echo on that person to make sure that the device has not migrated, that it didn't go anywhere, and we have a stable position, and then that patient can go home that same afternoon. So it's been a great procedure for the patients. It's ambulatory, in and out. It's a venous stick, so it's very, very low risk. Complications are really, really low, and the benefit is fairly large. It's reduced by like 40–50% the risks of repeat recurrent strokes. So you could leave that like that, and I guess I'll start it. I'll start it from there. We good? Okay. Could you take it out of presentation mode for a second? Okay. In any event, so that's what it looks like when you release the cable. There's no cable up there now, and the device is leveled itself out, and you can see very clearly that primum is inserted right in there, which is really, really nice. And this is what it looked like after. And I have a video on this. These videos are up on YouTube. And so there was a television show called The Good Doctor, and they had an episode with somebody who had a stroke and had a PFO or ASD, I forget which one it was, but they saw my videos online on YouTube, and I got a call from the producers of Channel 7 asking me if they could use our video to put on their screens, for their television program. So I said, well, I tell you what, I'll let you use my video, but on one condition. They go, what's that? I said, you don't have to pay me, but I want you to put on that these video images came from Maimonides Medical Center, so in the credits. So at the end of the show, they actually did that. So you can see here it says Amplatzer, courtesy of Maimonides. So we're very happy about that. So we got 15 seconds of fame on Channel 7 for this. So let's move on to some other things that we can do to reduce the risk of stroke in our patient population. So one of the other things we can do is sort of avant-garde. Hypertension, is a public health concern. There's tremendous amount of people who have hypertension, and it's a big risk factor. If we can reduce blood pressure, we can reduce our risk for cardiovascular disease and stroke. So 1 billion patients are affected worldwide. It costs us about $500 billion in direct costs. 50% of all heart disease and strokes are related to hypertensive heart disease. A 10 millimeter reduction in systolic blood pressure can lead to a 20% decrease in major cardiovascular events. And when we talk about stroke in particular, it's like 27%, just to get 10 millimeters reduction in blood pressure. Only 24% of the patients treated just with drugs have their blood pressure under control. That's pretty abysmal. That's a quarter of the patients, right? That's pretty abysmal. And 50% of our patients become non-adherent to antihypertensive therapy within 1 year. So, they're not compliant. So lo and behold, the companies have been working on these other ways to treat hypertension as an adjunct. And one of the devices we're going to talk about is a Medtronic device from the Simplicity trial for renal denervation. So Medtronic came up with this spiral system after failing before on other systems, but this is an interesting catheter. So we were one of the first in New York City to do this procedure, and it's called renal denervation. So somebody came up with this idea. Now I have to tell you, if one of my fellows ever came to me and said, Dr. Frankel, we have a great idea. We think what we should be doing is applying heat and barbecuing a kidney to reduce blood pressure, I would send them out the door running. I'd say, you got to get out of here. You need some help. But in fact, that's what this procedure is. It's bizarre, right? Somebody came up with this idea. Let's denervate the renal system for nervous system by applying heat through the renal artery. So what this catheter does, it's a spiral, hence the term Simplicity spiral. So this catheter has these 4 electrodes, 1, 2, 3, 4 on it. And it's a pretty smart catheter. The catheter will apply radiofrequency heat to the renal artery, and that heat will be transmitted to the nerves which surround the renal arteries, thereby denervating these nerves. So how do we know how much heat to apply? Well, through different testings that they've done, they know how much heat we can give without causing damage to the renal artery, causing strictures. So these electrodes right here, not only do they give heat, but they're also sensors. So they can tell what the temperatures are, and they will automatically shut down if the temperature at one of those thermistors exceeds a certain known value. So I'll show you some of the safety results with this catheter. It's a nice catheter. We can treat vessels anywhere from 3 millimeters to 8 millimeters, and the energy is delivered to the renal nerves. This is what it looks like on angio. You can see a catheter coming up here, entering the renal artery. A wire goes through here, straightens out that catheter, and then you can see the 1, 2, 3, 4 electrodes there that are going to be applying heat. So there's nothing permanent that stays in the patient, nothing left behind. The procedure takes about an hour to do, and it's pretty well tolerated. So one size fits all. What happens with this spiral catheter in a small artery, it's pretty much straightened out. And then in the larger artery, it obtains more of its spiral shape. But either way, all 4 of these electrodes are in contact with the blood vessel, delivering heat to the artery. If you look at safety outcomes at 1 month for the RDN procedure, 253 patients tested. Major events occurred in only 1. That's a pretty good outcome, 0.4%. All-cause death, 0. End-stage renal disease, 0. Embolic disease or knocking off plaque to the kidney, 0. Renal artery perforation, 0. Dissection, 0. There was 1 vascular complication requiring surgical repair. So if you think about that, that's pretty amazing because these are intra-arterial procedures. I mean, if I do 250 angioplasties or 250 cardiac catheterizations, it's likely we may have, a groin problem, a hematoma, or some vascular issue. So having 1 out of 253 is pretty safe device. So we're pretty happy with that. When we look at the effects of it, what happens when we treat these patients at 3 years? Well, you can see that the 24-hour systolic blood pressure readings, and that's patient goes home, he wears a 24-hour BP monitor just to check what the blood pressures are throughout the entire day, while they're working, while they're walking, and what happens when they're sleeping as well. You can see that there was an 18.7 millimeter drop in blood pressure versus the sham procedure that the patients got. only an 8.6% difference, a 10 millimeter change, p-value 0.004 out to 3 decimal places, highly statistically significant. If we look at the office blood pressure, there's a drop here of about almost 21. The sham procedure had a drop of about 12, a change of about 8.2. Statistically significant, no, not quite statistically significant, 0.07. So the drop in blood pressures that we get are durable. This chart here shows you what the drop in blood pressures are at 6 months, 1 year, 2 year, 3 years. So that's an important point, that the drop in blood pressure is durable, that the myelin does not grow back. Well, actually, there is no myelin on the renal artery nerves, which is an interesting phenomenon. So once we burn those nerves, they don't grow back. If it was a myelinated nerve, then we'd have the risk of it growing back and causing hypertension again. But we do not, and so it's pretty durable out to 3 years. You can see that there's still, it actually even gets better out of 3 years. So that's pretty good. We look at 3-year results, blood pressure reductions in a variety of high-risk subgroups. You take a look here at all the groups basically have a benefit, even stroke patients, reduction of about 21 millimeters of mercury, which is pretty good. What happened to the kidney function? You just did something terrible to the kidney. You were in there, you manipulated it with wires, you burned it, you caused all sorts of heat. What happens to your renal function? So these two lines, the dark blue one is people who have normal renal function greater than GFR greater than 60, and you can see there's a slight decrement with age over the 3-year period, but not statistically significant. And those patients who had renal insufficiency with the GFR less than 60, pretty much baseline, 45 to 43 GFR, no significant difference. So it's safe. So we were one of the first in New York to perform this procedure. Patients with uncontrolled hypertension who are anatomically suitable renal arteries that we could access and get to. Those patients had to have what we call resistant hypertension. They had to be on maximally tolerated doses of 3 or more antihypertensive drugs. So that's a big dose. You know, it's 3 drugs, but at maximal tolerated dose. So these people, we would really pretty much make them sick. I mean, if you have somebody in the office with a blood pressure of 180/90 and they're on 2 drugs, you add a third, you just want to get that blood pressure down. And so, you know, we keep treating them until they start complaining, either hypotension because the drugs are too strong, or dizziness or nausea. But we sort of get them to the point where they're at the maximally tolerated dose, and even still, they're still hypertensive. That's when we go ahead and do that procedure. We've done 10 procedures to date with a 10 to 20 millimeter drop in blood pressure 2 to 3 months after the procedure. So it's been highly successful for us. And I'll touch on one more device that we have to help reduce the risk of strokes. The Watchman, left atrial appendage closure. So we were also on the forefront of this when this device was first FDA approved. Again, that special metal called nitinol has nickel in it. It's an amazing metal. The beautiful part about this nitinol is it has tremendous memory. We can take this large catheter, this large device here, and squeeze it down into a small little catheter, deliver it through a hole that we make in the left atrium, in the septum, and delivers this to the left atrial appendage. And then that metal, that nitinol, has tremendous memory. You can crush it, you can step on it, you can drive a truck over it, and it's just going to come back to its normal shape. And that's what's allowed us to really advance the field of structural heart procedures, because we can take these large devices, crimp them down, and they don't get damaged, and they just come back to their normal shape. So this device is made in various sizes. Everybody has a different size and a different shape left atrial appendage. The left atrial appendage is sort of it's like a sac on top of the heart that clots will form in. And if you get clots in that sac on top of the heart, then you're at a high risk for having a stroke. Probably about 95% of the strokes that we see from the cardiac cause originate in the left atrial appendage. So why do people want to, why do people want this device? What's the utility of it? We have anticoagulation. We have some really good drugs, right? We had Coumadin, and now we have the NOACs. So, why do you want to have, something put into your left atrial appendage? Well, so some patients have issues with bleeding, right? Some patients, as they get older, they have GI bleeds, they're anemic, And so they can't really tolerate long-term anticoagulation. So if patients, who have a bleeding tendency or can't tolerate it, would benefit from this procedure because once we put this device in place, we usually wait about we give patients anticoagulation for about 6 weeks until this device is fully endothelialized. Once it's endothelialized, we bring the patient back and we do another echo on the patient to make sure that we have a good seal, that there's no blood going into this pouch here. Once we have this pouch sealed off, then there's no way blood can get in there and it can't clot and it can't come out. So we can stop the anticoagulation and people do really well. So this is what it looks like, the Watchman device. And on X-ray, it's hard to see here, but this is the Watchman device in place. You can see it's inside the left atrial appendage, this little sac here, and we have good margins, and it's jammed in there pretty good. And so once that's in place and endothelializes, we're in good shape. You look at the event rate, those patients who are on Watchman versus Coumadin, you can see the primary efficacy endpoint, 2.2 versus 3.7. All strokes reduced from 2.2 to 1.5. Systemic embolism was 0.2. Obviously, if you're just given drugs, there's nothing to embolize. Death, only 1 in the Watchman, where we had 2.3 in the warfarin group. So not only did it meet the non-inferiority, but it actually was superior to anticoagulation in all of these different categories. So using the Watchman device, we think is a really great thing to do for people. We're on the 2nd generation of Watchman now. It's the same day in and out procedure. It's a very, very well tolerated procedure. And yes, are there risks to it? Sure. Probably, certainly less than 1% risk. But being on long-term anticoagulation as we get older is also a risk, right? That's not a benign thing to be on anticoagulation. The other group of people that I think benefit from the Watchman device are younger patients who are in AFib who might want to stay active. So I can tell you that we have patients in our practice who are in their 50s, 40s, 50s, 60s that go into atrial fibrillation and they want to be active. They want to play basketball. They want to go skiing. They ride their bicycle and, having a fall or having trauma, being on anticoagulation is not a good thing. So if you really want to stay active as a younger person that has AFib, then getting the Watchman done and getting off the anticoagulation allows you to maintain your lifestyle and be active. I think that's it. Thank you.
Thank you, Dr. Frankel. Any questions? Just a couple quick questions in the audience and maybe one online. Anybody? Crystal clear in the audience. Let's look at the online question.
No, I don't treat lactogenesis. Sorry.
It talks about PFO closure in patients with both PFO and ASD, ASA. Yeah, that's one of the indications, right?
Yeah, so, having an atrial septal aneurysm definitely makes you a higher risk for recurrent stroke. So those are the ones that really should be treated, and we're pretty aggressive with that. We think it's a much better option. And, when you look at patients across the table who've had their first stroke, you just try to tell them that, once we have this device in place, there's a good chance that you'll have a 40 to 50% reduction in risk for a second stroke over medication alone. So we think it's a really good thing to do and a good idea to have that done. Okay, well, thanks very much. Appreciate it, guys.